Hello. So, in continuation of rapid review cardiology, valvular diseases, aortic stenosis we discussed just now, and we will be talking about the aortic regurgitation, which is also quite debilitating illness. So, the aortic valve regurgitates due to primary diseases of the valve leaflets or abnormalities of the aortic root and ascending aorta. So that is secondary. Primary because of the valve leaflets and the aortic root and ascending aorta because of the dilatation causes the AR. So that is the secondary AR. Chronic AR diseases of the valve leaflets, inadequate leaflet coaptation causing regurgitation, leaflet perforation in acute aortic regurgitation, and prolapse may also be caused, and which causes the subaortic stenosis. As I was explaining you, during the aortic stenosis, this turbulent jet hits the aortic valve, and this is one of the causes of aortic regurgitation. Should always be kept in mind. Perimembranous ventricular septal defect also has to be kept in mind because of the fact that there is a prolapse of the cusp of aortic valve in supracrystal VSD defects, and supracrystal VSD defects should always be closed very early on so that the patient doesn't develop this kind of complication. So major causes of chronic aortic regurgitation, leaflet abnormalities in our country, most important, no need to say, is because of the rheumatic fever, infective endocarditis, trauma, myxomatous degeneration may lead to AR, congenital aortic regurgitation is also an entity, SLE, rheumatoid and ankylosing. They cause the aortic regurgitation. Whipple's disease, Crohn's disease are another reasons. One important thing you should never forget is the anorectic drugs. They cause the valvulitis and valve thickening and may lead to regurgitation. So fenfluramine and phentermine, both the drugs can cause the aortic regurgitation. What are the secondary reasons for aortic regurgitation? Is age-related aortic dilatation may lead to this. Annuloaortic ectasia is also the one. Cystic medial necrosis because of the bicuspid aortic and Marfan syndrome. These lead to aortic regurgitation. Systemic hypertension also lead to aortic regurgitation. So aortitis in the form of syphilitic or giant cell may lead to this. Again, these four things rather, Reuters, ankylosing, Behçet's and psoriatic arthritis may be accompanied by aortic regurgitation. Other reasons are osteogenetic imperfecta, polychondritis and Ehlers-Danlos. These are to be kept in mind of the many reasons of chronic aortic regurgitation. So what happens in acute aortic regurgitation? Infective endocarditis, possibly the most important reason. Traumatic rupture of the valve will lead to this. Prostatic valve dysfunction will lead to aortic regurgitation, and aortic valvuloplasty, of course. Now it is not being undertaken and can only occur if you dilate the valve before the aortic valve replacement. So dehiscence of the pelevalvular leak and dehiscence of the prostatic valve will lead to aortic regurgitation in an acute way. Aortic root and this sorry about the interruption. So aortic root ascending aorta abnormalities in the form of acute aorta abnormalities of aortic dissection is the most common reason if it comes retrogradely, will cause the aortic regurgitation and an important feature. So what happens in aortic regurgitation? Diastolic regurgitation of the LV stroke, increase in left ventricular diastolic volume and raising the wall tension. Ventricle responds with the added wall tension by eccentric hypertrophy. So it's something different from the aortic stenosis alone. So during chronic compensated phase of AR, adapt to an increase in diastolic volume without significant increase in end diastolic volume. Over time, the progressive interstitial fibrosis reduces the compliance and lead to the decompensated phase. So the chronic decompensated phase, there is a volume overload, cardiac dilatation and the fall of the ejection fraction and forward stroke volume because of the afterload increase. This will lead to a heart failure situation and the patient may come as a symptom. So acute aortic regurgitation, effective forward stroke volume and the cardiac output fall. Patient goes into cardiogenic shock in acute AR. That is for sure that it is an medical emergency, and sudden increase in the diastolic pressure causes pre-closure of the mitral valve initially, but it can lead to diastolic mitral regurgitation and pulmonary edema. Diastolic mitral regurgitation here, and it will lead to pulmonary edema. Tachycardia is better in these cases because tachycardia helps shorten the diastolic filling period during which the mitral valve is open. Less the mitral valve is open, better it is, and that will prevent the pulmonary edema in acute MR cases. This is one example of, I should say, a EDM, the early diastolic murmur, which is the classical of aortic regurgitation. High-pitched murmur, and if you make the patient sit and lean forward, it becomes nearer to the stethoscope. So it is better heard. In the same way, the S2 may be very soft because of inadequate coaptation of the aortic valve and the aortic regurgitation. So it is an important sign. What are the eponymous signs? All the signs of hyperdynamic pulses. These are fancy to know also, and you see them also. These are usually vascular. So water hammer pulse is a rapid upstroke and quick collapse. De Musse is a head bobbing with every pulse. Tribes is a pistol shot sound over the femoral artery. Proximal systole, distal diastole. Mueller is a systolic pulsation of the uvula. Quincks is capillary pulsation nail bed. Hill sign is the 60 millimeter difference between the upper limb and lower limb. Lower limb more. Baker sign is arterial pulsation in the retinal artery on fundoscopy. Can be seen very easily. De Rosie's murmur on the femoral artery, compressed proximally and distally, as I have told you. So these are all the signs of hyperdynamic circulation and a big volume pulse because of the lot of increase in the pulse pressure. So angiographic grading of the AR, important to see. What happens if you inject dye into the aorta with a pigtail catheter? So the degree of the MR, mild, moderate, moderately severe and severe. Just look, interesting. There is a faint and incomplete opacification of the left ventricle upon injecting in the aorta, and it clears rapidly. Moderate also, it clears rapidly, but the opacification is complete, equal to the aortic opacification where you are giving the injection, equal. Greater than aortic opacification is a very severe grade for AR. So these are the angiographic gradings of the aortic regurgitation which are important to see. Besparian pulse, as we have explained earlier also, in severe AR the pulse may be a double peak because of the flow. Cardiac findings: laterally displaced apex beat, diminished mitral closure sound as we were talking just now, and decrescendo hollow diastolic murmur, maybe hollow diastolic, maybe a decrescendo murmur, and very a blowing quality. Not very difficult to see also. Right sternal border in aortic dilatation. So it's a good thing. It is a secondary aortic regurgitation. If it is heard better on the right side, it's a aortic dilatation murmur. So it will be heard in secondary aortic regurgitation, and if the diastolic murmur is heard on the left side, it is primarily due to valvular AR. It is a good differentiation, although may not be accurate, but this may happen. There may be a soft systolic murmur of the increased flow across the valve, across the aortic valve. So that is a flow murmur in severe AR. What further happens into the low pitched mitral stenosis, like a Austin Flint murmur? Again a very good murmur because the regurgitant jet strokes the anterior leaflet of the mitral valve. This is heard and should be looked for, and you may confuse it with the presence of mitral stenosis along with aortic regurgitation. What is there in ECG? Left ventricular hypertrophy. You will definitely see one of the largest hearts in valvular diseases. You will find them. Increased LV size and cardiomegaly will be there. Aorta aneurysmal may also be seen as far as the X-ray is concerned or ECG is concerned. Echocardiography diagnostic for the causative reason and for the detail of the aortic regurgitation, the morphology, as well as the need for the surgery. So the LV size and ejection fractions important to monitor from time to time, should be considered every year in a way, because the aortic regurgitation is one disease which can be tolerated for years together before the operation is taken up. So aortic pathology easy to see as far as the echo is concerned before the AR becomes severe. The aortic valve morphology like bicuspids, prolapse, vegetations and rheumatic changes. These are all quite easily available in echocardiography. So what happens in the Doppler, because this is what determines the need for the surgery. So regurgitant jet width. This width, if it is more than 50% of the LVOT, that is the outflow tract. If the regurgitant jet is this much, go for the surgery. Presence of proximal PISA, if it is more than 0.3 centimeter, severe AR. If the pressure half time is less than 250, don't worry, more than 400, surgery then and there. So these are PHT, isovelocity, that is the PISA, and the regurgitant orifices. These are important for determining the need for the surgery. In the same way, if the slow degradation of the gradient, I have talked about it, and diastolic flow reversal in the descending aorta is also a very important finding as far as the AR is concerned. If the regurgitant flow is more than 25 centimeter per second, then it is an indication for surgery. So these are the indications for surgery. What is the medical therapy? ACE inhibitors, we have been giving it for years together, but recent studies say that it causes more of the fibrotic changes and it may lead to problems unnecessary. Acute AR hemodynamic stabilization with nitroprusides, and these treatments are very important. The basic reason of endocarditis should be treated. Intra-aortic balloon insertion should not be done as far as the aortic regurgitation is concerned, and if it is much more contraindicated if there is a aortic dissection. So don't forget, in AR don't put a IABP. More AR will be caused and the patient will collapse. Surgical therapy in symptomatic patients regardless of the ejection fraction. Don't worry about that. Asymptomatic patients, if the ejection fraction is less than 50%, just marginal, do the operation. LV dilatation, these are the figures. Systolic and systolic diameter of 50 should be the cutoff margin. In the same way, diastolic diameter of 65 should be the cutoff margin. Aortic repair doesn't play much role.